Thank you all for joining the Michigan Opioid Collaborative webinar titled Expanding Access to Medication for Opioid Use Disorder Through Medication First, Low Barrier Models of Care. My name is Tim Hudson. I'm a behavioral health consultant with Michigan Opioid Collaborative. I cover the northern 21 counties. As you see on the screen, we have the QR code posted for CMEs, and we'll also post this along with the survey. The CEU survey will be posted throughout the chat throughout the time of this webinar. You'll have 48 hours to request and complete the survey for educational credits. And for those of you who haven't done so, if you could please sign into the chat with your name, place of employment, and email address. Throughout the course of this presentation, if you have questions, please feel free to post those in the chat or raise your hand. We'll definitely make sure that we get those questions answered. To start, I'm going to do an overview of what we do here at the Michigan Opioid Collaborative. So we are a grant-funded program within the University of Michigan. We are funded by Blue Cross Blue Shield of Michigan and the Michigan Department of Health and Human Services. We offer free same-day patient consults with an addiction physician in areas such as MAT inductions and guidance, options for chronic pain, and obtaining community resources and referrals. We hold free monthly webinars and case consultations around polysubstance use and treating different substance use disorders. Additionally, we host free education and trainings tailored to your office around SUDs, MAT, technical assistance with MAT office setup, and general addiction treatment. We collaborate with Great Moms Model of Care to provide support around diagnosing and treating pregnant perinatal patients with substance use disorders. We have a hepatologist on staff who provides education, case consultation, and a 3-part webinar series on Hep C. And we participate in a number of community events focusing on community coalitions to build connections and work to increase awareness of SUDs, the benefits of medication for opioid use disorder, and reduce stigma. All right, I'm going to introduce our host. Dr. Eliza Hutchinson is a family physician in Seattle, Washington. She completed medical school at the University of Washington School of Medicine and residency at Swedish First Hill in Seattle. She's a primary care provider at Country Doctor Community Health Centers, a federally qualified health center focusing on care for people living unhoused, those with substance use disorders, and justice-involved individuals. She serves as clinical site director for the Seattle STEP Clinic, a collaboration between multidisciplinary community agencies providing medications for opioid use disorder in a low-barrier harm reduction model. She's also the clinical site director for the Recovery Cafe Health Resource Center, a nursing-based outreach clinic serving individuals in recovery. She is an enthusiastic advocate for harm reduction principles, innovative models of care for marginalized populations, and decreasing stigma for individuals with substance use disorder. Otherwise, you can find her soaking in the outdoors with her family on bike, paddleboard, rollerblades, or dancing to salsa. I'll turn over to you, Dr. Hutchinson.
All right, thank you so much. Pleasure to be here with you all. I'm going to go ahead and share my screen. Let's see. Make sure that you can see me. All right, can you see that okay?
I'm not seeing, oh, okay, there it is.
There we go. We good now?
Yep.
Okay, excellent, great. Well, pleasure to be here with you all, and thanks for the introduction. So just a little word about myself and a couple of things about how we'll proceed through the presentation before we get started. So can see all the places I'm located in Seattle for just, well, I'm working in Seattle still technically for one more day, and then I actually have just moved to Michigan and will be unemployed for a couple months this summer, and then actually working at University of Michigan and Packard Health. So really excited to be joining the Michigan community here. And I know there's a rich body of experience and knowledge here in the virtual room. So really excited to sort of meet you all and learn about your experience through your participation today. As we go through the presentation, I'm really thrilled for you to ask questions, comments. An hour is a long time for me to just talk at you. So please do raise hand, put anything in the chat, and I'll pause specifically a couple times through the presentation to address questions or comments as they come up. And then I do have a couple areas where I'd love your participation, and I'll call that out as well. And then just a word kind of on terminology before we get rolling. So, there's MOUD, MAT. I tend to use MOUD, so you'll hear me refer to that throughout the presentation. And that, of course, encompasses 3 different medications, but I'll really be focusing on buprenorphine today. And I'll often just say bupe, just so everyone knows what I mean by that. And then I'll also be talking about sort of medication first, low barrier models. You'll hear lots of terminology for this as well. So you'll kind of hear me use them interchangeably through the presentation as well. So with that, let's get started. I have no disclosures. And today what we're going to try to do is really identify barriers to accessing MOUD and sort of more traditional clinical models, and explain how medication first models can help address some of these challenges. And then secondly, hopefully you'll be able to come away describing some strategies for incorporating harm reduction principles into the clinical management of OUD. And thirdly, we'll discuss how more innovative models of clinical care, particularly in the community setting, can really expand access to vital medical care to our vulnerable community members. So to get started, you'll see my slide just stopped moving. There we go. This is again kind of just where we're going. We're going to introduce you to 2 specific patients of mine and sort of their general trajectories, and then lead into thinking about sort of why do we need these kinds of models. I'll take you through a little bit about Seattle Step Clinic, where I currently work, and then sort of stepping back and thinking about, does this kind of care really work at all? And then we'll love to have conversation at the end. So to begin with, I wanted to introduce you to one of my patients, actually from my residency clinic. You all have met many folks like this. He's a 24-year-old guy. He's got opioid use disorder, primarily via injection, now also using blue pills. He has a remote history of alcohol use disorder, but is now sober and very stable from that standpoint. He's got mild generalized anxiety disorder and otherwise is really healthy. He's housed, he's self-employed, and has good, reliable transportation. He also has good social support and has a lot of peers and some family members who are not. He came to me from my primary care residency and thrived and did really well from there. Many of us have taken care of patients like this, and they.
I'm sorry, Dr. Hutchinson, we lost sound. Well, there, I can hear you now.
Oh, strange. Sorry, I am in a brand new house with maybe a spotty internet connection, so call out if I'm having issues. Anyway, whoops, sorry, I'll go back to that one. So anyway, these sorts of folks really fit beautifully into a lot of the models that we've built, the sort of more traditional office-based models where I trained, and particularly ones that prioritize sort of abstinence-based models. And these folks are really satisfying to work with, right? However, many of us have also probably taken care of folks a little bit more like the next one who I'll introduce you to. And this is a 46-year-old female named KRISTEN. She also has OUD via injection, but also benzodiazepine use and methamphetamine use disorder. She has some past medical history of hepatitis C that was untreated, Crohn's disease, and hypertension, all of those untreated for many years because she hasn't been in any medical care. Also severe generalized anxiety disorder. She's very unstably housed, sometimes with her boyfriend in an RV, but oftentimes on the street or in a tent, and she's unemployed and doesn't have any transportation. She also has, her social circle is really full of folks who are also with active SUDs as well. And when she came to me, she had been discharged from multiple MOUD programs for missing appointments, for having ongoing substance use, and particularly for her benzodiazepine use. Many of us, in sort of a traditional, particularly office-based clinical model, might sort of cringe when we see this patient on our schedule, just sort of thinking, we don't know how to begin tackling their medical, their psychiatric, their social problems, and really, whether we can make a difference in their lives. And luckily, I met this particular patient at Seattle Step Clinic, and this was our low barrier program where we had a very different structure and a lot of added layers of support to work with her. And so I'll be able to describe at the end a little bit more about her trajectory. So these 2 folks really, make me think of, this is my little hand drawing of sort of 2 trajectories that I think about. And Brian and KRISTEN really represent, I think more broadly, these 2 very different paths for folks in achieving their goals of decreasing opioid use. And kind of as a side note, we also see these paths in many other chronic diseases, right? Whether it's a patient trying to achieve better glucose control. Some people take a straight path and some people take a more meandering path. And really both individuals can arrive at the same end goal, but the route is really different. Many of our more traditional models, like the one that I was trained in, and really healthcare in general, are built sort of for the Bryans of the world, that left straight arrow. Folks who arrive consistently for their appointments, they start their medication, and then they quickly stop using opioids and other substances. However, I certainly found in my practice, and many of you have seen this as well in your settings, that approach doesn't work for everybody, and in fact, not for a lot of folks. And really, I think if we conceptualize addiction as sort of the chronic relapsing disease that we know it is, it's easy to understand why that model is difficult for folks. In that traditional model, each relapse or each lack of timely follow-up is often a reason to discharge a patient or sort of punish the patient. And that approach, really, when we think about, from my position as a medical provider, the way we treat many other chronic medical diseases, that approach is very discrepant. For instance, if we have a patient with diabetes who stops using their insulin and their blood sugars are really out of control, and we don't tell them to go away and come back when they are doing a bit better, we really ramp up support. We do phone calls, we set them up with our nurse, and really, give them as much extra support as we can. So kind of by failing to apply that same sort of principle of chronic disease management for OUD, at least what I was seeing in my clinic is that we were really missing opportunities to engage the folks in care who are most struggling with their OUD. And that observation really led my team and others across the country, and perhaps folks on the call here, to rethink a little bit about the models in which we deliver MOUD to help meet the needs of folks like KRISTEN in the world. So before we just kind of dive into discussing that model of care, I wanted to sort of outline what maybe doesn't work and what are some barriers in more traditional office-based settings. And I'm curious if folks wanted to share, some of the things that they've seen folks struggle with when trying to get started or stay on MOUD in various settings. So I'd love if you want to write in the chat, or if you want to unmute yourself and share anything that you've seen. Oops. I'm seeing transportation, absolutely a big one. Other folks seeing judgment, yes, absolutely. We'll talk about that one. Childcare, yes. As my toddler is running around in the background, I'm thinking about that one, absolutely. It was about being okay, and enclosed space of, difficulty due to past trauma, and the office spaces being difficult. Schedules, no access to telehealth, no openings, providers willing to prescribe, losing the medication, coordinating psychiatric care, wait list for services. Yes, absolutely. Cost, yes, all the time. Contacting patients who are living homeless. Yes, patients need to be seen by the therapist at that specific treatment center. Yes, COVID. Oh yeah. Pharmacy. Sure. Great. This is a very robust list, and more than I even had lost. Staff shortages. Yes. Thank you for these. Yes, multiple drug use for the conflicts for the provider. Yes, thank you. This is a million things you all have listed. This is my list, and you kind of went through most of these. But really, many things we mentioned, misappointments, people arriving late, oftentimes due to transportation or other things going on in their lives. We often see, delay in medication start, and that can be for financial reasons. That can be because the provider doesn't prescribe on the first day. Pharmacy challenges, again, might be transportation. It might be cost issues. It might be stigma and judgment in the pharmacy, ID requirements. Financial and insurance limitations, which can manifest in many different ways, and expectations kind of put on there. I think so folks referred to sort of like multiple substances being used and that being difficult. Yes, returning to jail, someone just tossed out, absolutely. And then, judgment and stigma, which I think can underlie a lot of these other issues. And I also put triage of needs on there, especially for our folks. And you often see, getting to a clinic visit, yes, it's on their list of priorities, but maybe the top 3 are finding food, taking care of their child, and finding a place to stay that night. And so making it to their visit on time just doesn't necessarily rise to the top. And then I also added dosing limits here. This is something we've seen, and I'll talk a little bit more. But in some models, there are sort of strict limits on how high folks will go in their dosing of buprenorphine, and we know that some folks really need a higher dose. So that can also be a challenge for retention and care for folks. So, if we really look at this, we look at this list here and the list that you all came up with, and it really is actually quite challenging for folks to make it in some of these more traditional settings without a lot of psychosocial supports to go along with it. And if we look at the data, we really see that difficulty panning out in the numbers of who's accessing this care. So if we look at sort of, first of all, this is a syringe service program in Washington, did a survey in 2017 and talked to a couple thousand folks who are actively using. And first of all, asked folks, did they even want to reduce their opioid use? And absolutely, yes, by and large, people really do want to reduce their opioid use. And then specifically, what do people really want? They want to be able to take OUD medication. So if you look at 69%, that's really what folks want. And within those OUD medications, buprenorphine is by and large what people are most looking for. So the desire is there and the interest is there on the part of folks using opioids. And then when you ask people sort of like, why do they avoid seeking medical care? This is some of what was already listed, but the top reasons is certainly, don't trust or don't like their doctors and, have had bad experiences in the past or don't want to be judged or lectured about their drug use. So, the desire for folks to want MOUD is really well aligned with what we see in the data. And of course, I think everybody here knows MOUD is a really powerful set of tools that we have to help folks with OUD. So this is a slide kind of just showing, over time, sort of the number of relapses based on what kind of treatment folks had. And we see that folks on buprenorphine and methadone very rapidly decrease their risk of relapse and really maintain that over time. And folks who are using more sort of behavioral health-based services absolutely do over a long period of time reduce their risk of relapse, but it takes longer than the other medications. And then, as we also know, buprenorphine just flat out very early on saves lives and has a tremendous decrease in mortality for folks who are taking it. And then, now that we know, of course, that this is such a life-saving medication, the answer to their question is sort of why isn't everyone on it? If you really look across the data, various studies report different numbers, but really probably less than 20% of folks with OUD are actually receiving OUD-specific treatment of any kind. So really, there's a huge gap in terms of what people want and what we're able to provide as a community. How can we expand access? And of course, my answer to that is that one piece of it is that we need to adopt some different approaches to how we treat, including a medication first or low barrier type of model. So I'm going to pause first of all to just ask any questions and then want to ask folks to reflect on this slide and either type your question into the chat or tell me what comes to mind when you hear these terms here. Let's see. Oh yeah, and I have a question here. Why are so many healthcare providers so opposed to methadone use? It seemed there would be more progress being made in this area. Interesting. Yeah, and I think, lots of layers to this. And I think in general, there's actually a fair bit of stigma against methadone, both among patients and the community, as well as healthcare providers. And I'll be curious if other folks in the Michigan realm have a specific thought about that in Michigan. But I know certainly in Seattle, I think a lot of folks, feel like methadone, first of all, patients don't like methadone simply because of the structure that often comes with it. And I think then there's a lot of stigma as well among providers and healthcare and community members of sort of seeing folks maybe who've been improperly dosed on methadone and who are nodding off or seem groggy. And I know that is definitely something that I hear from providers sometimes is that, methadone sort of makes people more drugged out. And I think that's oftentimes a result of improper dosing. But certainly if other people have other thoughts on that, please chime in.
There are a few comments in the chat. There's a resistance to believing the data, a lack of time, and pressure. It's difficult to get patients into medication with low barriers and thresholds. lots of barriers and obstacles. Another comment says stigma with methadone, lots of barriers for methadone, mostly transportation. Methadone has to be dosed daily. It's difficult to get to the clinic daily.
Yeah, absolutely. I think those are all very, very well stated. Absolutely. But yes, you're right. It's such a powerful tool. And I think that's something that I try in my practice all the time to remember that even though buprenorphine is the thing that I can prescribe, for some folks, methadone is absolutely going to be the answer. So folks hear the term, whether you've heard it before or not, and maybe not, but if you hear the term medication first or low barrier or low threshold type of treatment, what does that mean for folks? What comes to mind? Accessibility, yes. Patients not being dismissed for ongoing drug use. Sure, yep. Anything else if folks have heard that term? Yep, getting people stable and then focusing on foundational improvements, that well stated. And ER access, maybe meeting the patient where they're at. Not quite sure if I understand the ER of access, so maybe someone can clarify. Not having to jump through a million hoops. Yeah, I think very well stated. Stabilizing symptoms. Emergency room access. Okay, yep, got it. Thank you for that. Yep, low barrier ER access. Something definitely we're trying to champion. Yep, absolutely. So thank you for all of those. These are sort of what the literature shows and sort of I'll talk about in our program. But there's a small but growing body of literature so far in terms of this type of care. There are a few foundational characteristics sort of across, I see someone entered a trauma-informed environment, absolutely. Key characteristics that we really see across all of these programs that are growing is rapid access to care and medication, meaning you can get an appointment basically on the same day or maybe the next day, and importantly that you can start the medication on the same day without any delay. Many of these are really focused with sort of a harm reduction approach, and I'll talk some more about that. Flexibility, right? Meaning flexibility in all kinds of ways, whether that's dosing requirements, whether that's in terms of not requiring abstinence, whether that's flexibility in terms of appointment times or having a walk-in setting. And then a convenient location. The folks who are accessing these programs often don't have great transportation or don't have time to go far out of the way. So locating these programs in a place that makes sense. And then some specific programs also, do have drop-in hours. So again, no specific appointments needed. Peer support is something that's available in many programs as well and can be really powerful, particularly for enacting the harm reduction approach. Offering other non-medical services on site. And then some are also able to offer an on-site pharmacy, which can remedy a lot of those pharmacy issues that folks mentioned previously. So anyways, a lot of these programs have similar characteristics, but everyone sort of has their own flavor. And so I wanted to sort of walk you through our interpretation of this model at Step Clinic. And so Step Clinic is, again, what we like to consider sort of a one-stop shopping for folks. So we're a partnership in Seattle, kind of right at the edge of downtown. We've been around for about 3 years, started with SAMHSA funding, all grant funding, and are working towards sustainability via billing Medicaid. And importantly, we are located sort of in this downtown area, and we're within the setting of what's called the Hepatitis Education Project, which hosts a syringe service program, as well as some other infectious disease testing and other basic case management services. And our real clinical approach to STDs, I feel like, is a sort of a chronic disease model, but founded in harm reduction principles. So how do we really enact this model? Here on the left is sort of the list of barriers to care that we already discussed, and then on the right is sort of how we attempt to remedy that. So again, we have same-day starts of medication. So usually anybody interested in our services can come, and on that very first day, they'll have an appointment and they'll get their medication prescription on that same day. To remedy some of the judgment and stigma pieces, we really found ourselves in a harm reduction approach, and we have peers who really helped make sure that we adhere to that philosophy. We're very flexible in terms of we really don't have appointments. We have folks drop in whenever they possibly can, and oftentimes that's not on the day that we anticipate that they will drop in based on their prescription running out, but our doors are open to them anytime. to help folks kind of meet all their basic needs at once. We try to be a one-stop shop. And I'll talk a little bit more about what folks do when they come into the clinic. But we do have, additional services available like free clothing, sometimes vouchers, bus tickets, that sort of thing. We don't have our own on-site pharmacy, but we have very tight relationships with some local pharmacies that we've identified who, don't require identification and who seem to treat our folks with a lot of respect. And so we tend to use those particular pharmacies. A lot of folks come to us without their Medicaid activated, but are indeed eligible for Medicaid. That's oftentimes folks coming out of incarceration when Medicaid is paused. So we're able to activate Medicaid on the spot for folks so they can get their medication that day. We don't require abstinence or really have any expectation for abstinence. And we also don't require behavioral health, although we do offer it as well, but it's not, the medication's never contingent on that participation. And we also do escalate the dose up to the highest level when it's clinically indicated, which we tend to be doing more and more in the setting of fentanyl right now. So if anybody's brain works like mine, you won't remember this bullet pointed list. So I just wanted to kind of go through what our staffing model looks like and then what a day in clinic looks like for folks.
There's a question in the chat that says, do you have a crisis number or a number to call for audio or Zoom appointments?
Oh, good question. Gosh, we don't have a specific crisis number. I wish that we did. Something we're working toward. We're only there 3 days a week right now, and we're working toward more around the clock access. But we do have a phone number, absolutely, that people can call for telehealth appointments. So we do telehealth intakes and follow-ups when folks are able. And sometimes folks will actually be, an outreach worker will be out in the field and can call in with that person if the person doesn't have a telephone. So yes, absolutely. And I will share those at the end of the presentation for sure. And then, so in terms of our staffing, multidisciplinary is really key here. And what was really important in our founding is, again, not to feel particularly medical. Someone mentioned when you think about sort of a trauma-informed approach, oftentimes very medical settings are really quite terrifying for folks. And so our goal is really not to feel that way. So the medical team is just a small portion of who's here. So our patient care navigators, or sometimes they'll say navigators or PCNs, we have several of those, and a couple of them are peers who are also on buprenorphine themselves, so can really share a relationship with the patients that I cannot do as a medical provider. We have a clinic coordinator who sort of runs our entire clinic flow and also can share her own experience with patients as well. She'll activate people's insurance and work with them on troubleshooting the financial logistics. We work with a nurse care manager model. So the nurse is doing the majority of the medical visit, and then there's just a small amount of time with the provider. We have medical providers who are nurse practitioners or MDs currently. And then behavioral health counselors are available previously in person, currently only via telehealth. And again, that piece is not required, but it's available sort of in a warm handoff model for anyone who's interested at the time. So before I go into sort of a clinic day, I did want to just dip into harm reduction briefly. I know many of you may be really well versed. I know there was just a fantastic harm reduction conference here, but I didn't get any of this in my medical training. So I just wanted to spend a moment on that. So these are sort of, various tenets of the philosophies of harm reduction here that I wanted to walk through and sort of how we enact them at STEP. So the first one being, minimizing harm as best we can. And for us, our key tool really is doing our best to start people rapidly and keep them on buprenorphine, because again, we know it decreases mortality and morbidity very rapidly as soon as people are on it. So we do our best using all of our low barrier approaches to keep people on their medication. And then we also do a lot of very specific safer use education, in part from the medical team, so from the nurse and the provider, but then really having folks work with our peers and with the syringe service program. You can see the picture of the syringe service table there, so that folks really have a good understanding of all the safer use strategies that they possibly can, sort of acknowledging that ongoing use is going to be a reality for many folks. Redefining success, I think this is something, right, that we all try to do in all of our practices. And I'm just reading a question. Seems like to have a behavioral health assessment, at least at the start of treatment, to help providers identify trouble areas would be a good thing. Absolutely, yeah. And that's actually something that we're sort of playing with our with our telehealth providers is how to integrate them a bit into the first visit or at least the second visit. Oftentimes folks are a little bit overwhelmed on the first visit with what they already have to do to get the medication. But we actually are providers kind of working with a psychiatrist to help us integrate a little bit more of a psychiatric assessment as well into our intake. But yes, absolutely, it can add a lot of additional dimensions. So again, redefining success, something that we all try to do, but it's always a work in progress, right? And really recognizing that the thing that I think someone should do and feel is important as a medical provider is maybe not at all what's important to them. So we really spend a lot of time drilling down with our patients, what are their goals and what are their values? What is success going to look like for them? And then whatever their goal is, we ask on intake, we keep that in the problem list and we keep it front and center on our minds when we're working with the patient. So we can always recenter ourselves back to that goal when we do our motivational interviewing. And these are just a few goals that our folks have listed. And decreasing opioid use is usually a goal for folks, obviously, who are coming, but I often try to drill down to sort of what's beneath that, right? Like, what are the values, what's going on in somebody's life that heroin use or fentanyl use is impacting, to really center down to what's the more foundational goal for somebody. And then non-judgmental approaches, which someone mentioned, judgment is so key. And again, we do our very best to honor everybody's goals and values and really have curiosity and compassion when we're approaching them, and seeing ourselves really as consultants and supports, but not as experts in who the people are or what they need. And then dignity and respect, we try to embody this in everything that we do, but one way that it really can play out, I think specifically, is language. And when I was in medical training, certainly the terms on the left were really all the terms that we were trained in. And we try best to use the terms on the right. Oftentimes patients actually do still respond more to the terms on the left and use them themselves, but we try our best to sort of work with the terms on the right that feel more respectful to folks. And then empowering folks with knowledge. Again, we believe that every person is really their own best decision maker when they're equipped with knowledge and good consultation. So again, I try to provide as much factual and unfiltered information as I can, about medical complications of substance use, about the pharmacology of buprenorphine, and then really letting folks make their own decisions. And one thing, for example, that I try to spend a lot of time on when we do an intake with somebody is acknowledging that they may decide they want to go off their medication or take a buprenorphine holiday, just like some patients take insulin holidays or they stop their inhalers. I spend a lot of time talking to people about how to restart their medication in a safe way, so that they sort of know that I understand that's a reality, and we can equip them with knowledge to get back on as quickly as they can. So how does this actually look in clinic? This is sort of what a patient visit is at STEP Clinic. So when they first come, they meet with the patient care navigator who, if it's a brand new patient, they'll sort of do an introduction, explain the basic tenets of the program, and sort of judge the patient's interest. And then if the patient wants to go forth with a visit, the patient will meet briefly with our clinic coordinator to activate any insurance and get registered in our system. And then the next stop is the patient, well, usually the navigator, I should say, will give a urine drug screen cup to the patient, and the urine drug screen is encouraged but not required. And later I'm happy to dive more into urine drug screens at the end if that's a topic of interest for folks. But we encourage it, don't require it. And then the patient goes on and meets with our nurse care manager, and that's really the bulk of that first visit. And often the follow-up visits is spending time with the nurse, who will do the initial intake and then all of the follow-up visits. And a lot of the intake is, again, confirming the diagnosis, finding out the history, what medications have worked in the past, what hasn't worked, any other medical issues, and then talking through medication start instructions. And probably as you all are, at this point, we really are seeing many folks who are already familiar with how to start buprenorphine. So that counseling, we still do it, but a lot of people have the way they already do it. And then we have the visit with the provider, which is usually very brief to confirm the diagnosis and address any of their medical concerns. And then at the end, the person wraps up with the navigator again, sort of to bookend the appointment. The navigator will debrief the visit, see how things went, if the patient has remaining questions. And then the services there on the right, behavioral health, hepatitis C testing, SSP services, syringe service program services. Those are all optional, all encouraged, and we check in basically at every visit if folks want to access those. but they're not required to do so. And then, as I mentioned, we're really, of course, focused on MOUD and what's associated with that, but medical needs and unmet medical needs is something we've been seeing throughout the course of time we've been there. So we're actually trying to expand our scope a little bit to encompass more than just MOUD. So you can see we're sort of working incrementally. We were able to add hepatitis C treatment. Testing was already done on site, but we now are able to treat on site. We've added vaccines, particularly when COVID came around, and we have a highly unvaccinated population. We've now been able to add some in-clinic medications like Depo-Provera is a big one, a lot of folks without any contraception. And then STI testing and treatment was our newest addition, and our next hope is to add PrEP and kind of work our way from there into becoming as much of a harm reduction primary care center as we can, really recognizing that a lot of our folks haven't and won't probably seek care in a standard medical clinic. So that is sort of the model. And do we offer HIV testing? Yes, we absolutely do. We currently don't offer treatment on site. That's another dream, but we do offer testing for folks. And then the primary clinic I'm associated with has a very robust HIV team, and so we can refer folks there in the event of a positive test. So who are our patients? This is pretty similar to many other low barrier models, but we tend to have a fairly young-ish population at this point, largely male, largely white. We do have, actually, compared to other Seattle programs, we do have a larger population of color, but less so than other cities such as San Francisco or New York, which sort of mirrors the populations there. But we're also undergoing a lot of additional work to try to figure out how to better reach communities of color. And we have a nurse practitioner doing a dissertation and a project on that. So hopefully that will be improving over time. And then our folks are, really medically and socially complex, as I've already alluded to. So, the great majority of our folks are experiencing homelessness or some kind of significant instability in their housing, most with a history of incarceration, often very recent, often ongoing, pending involvement in the criminal legal system. And then a lot of hepatitis C. Almost everyone is eligible for Medicaid, which is really helpful because we're almost always able to activate that for folks. Almost everyone is using multiple substances, has history of overdoses, and again, a lot of unmet medical and mental health needs. Most folks are not established with a primary care provider, mostly use emergency services for their care. So now I just want to turn to sort of like, does this even work? This model, it's something that I feel very strongly about in my heart, and it feels like it works, but it is important to look at the numbers and see on a larger scale, does this kind of care work? So our clinic is still fairly new, young, and we're sort of community health and unfortunately don't have a big research arm. So we look to some other programs very similar to us. And most of the literature looks particularly at retention in care, right? Because we know that if we keep people in care and on medication, that's going to decrease their mortality rates. So retention in care is one, and then also looking at rates of opioid use showing up in urine drug testing is the most common. So this is a program right down the street in Seattle, who we were modeled very similarly after. And they did look at retention and sort of, characterize folks. They categorized low, moderate, and high retention based on how long folks were in care. And the high retention category was about like 4 to 6 months. So you can see the numbers there, goes down to 27%, or to up to 27%, sorry, in the higher retention. And then, a lot of folks who don't make it back after the first visit, and then a number in between. And they did see decreased opioid use over the course of their study. They looked between the first and the 6th visit, and they saw that the positive urine drug testing showed 96%, so 96% adherence to buprenorphine, and then similarly the opioid positive urine drug screens decreased down to 41% during that same time. So definitely some retention, some decreased opioid use. We see similar rates of retention in these other studies. The one on the left was a street-based clinic in San Francisco. And they showed similar, they use slightly different measures of retention, but we see sort of similarly around 4 to 6 months out, like around 30% retention, similar to the other program. And then the article on the right also again, looked at retention in a slightly different way, and then also looked at the positive urine drug screens and basically showed over time people stayed on their buprenorphine and then decreased their opioid use at the same time. So what do we make of all this retention data? I guess the comparison is really difficult, I think, for two reasons. One is no one has really used a standardized measure of retention yet. Everyone's is a little bit different, so difficult to compare. In the larger MOUD literature, sort of the non-low barrier, more historically, there's a huge range of retention reported at about 180 days from 21% to 65%. So I think, these programs sort of fall within that category, but the range is wide, obviously. And then the second difficulty is, the low barrier populations are very, very different than many other traditional programs. So a little bit of comparing apples to oranges in terms of that. But that is something that we can look at, and we still are sort of in that window of other programs. And then very interesting, the other piece of literature I'll share, which someone just sent to me right before this presentation, is there's actually a study that recently showed that low barrier tendencies for a provider in a program actually may specifically increase retention. And this was a big study that looked at patient and provider factors in retention and care. And they actually found that there were 5 specific sort of high barrier or high threshold practices that decreased folks' retention. So that was these listed here. The first was the in-office medication start. And then specifically the strongest correlate was a requirement for the psychosocial treatment. And then people being discharged in response to ongoing substance use or missed visits. And folks who were encouraging just a short duration of treatment instead of more of a chronic management with buprenorphine. So I think that's also, really, really provocative data for us to think about as well. But anyway, kind of all of that together, I really feel like, we're basically targeting a population of folks who are not in care at all otherwise. So any amount of retention, any amount of buprenorphine we can get for folks is a strong step in the right direction, but still a lot of work to be done in terms of research looking at these programs. And another way that I think about it, sort of at step clinic at least, is also, what are we doing in terms of other health conditions for folks? Because people matter more than just their MOUD status. So one is, are people getting tested for Hep C? And then, again, we're starting treatment, but our rates are very low right now. And then are we able to link them to primary care? And that number, that 10%, is much lower than we'd like it to be. And our initial model actually was to link people to primary care at local clinics, but we learned that leap was a struggle for a lot of folks. And so again, we're sort of pivoting now to trying to bring health services to people at step clinic instead of trying to get them to go to a more standard medical clinic. So hopefully we'll just be bringing more services to folks in the very near future. And then I guess then we can go back and look at what happens with patients in this setting. And so we can kind of return to KRISTEN, who was sort of the more wiggly path on her trajectory. And again, polysubstance use, a lot of psychosocial instability, and had been discharged from a lot of other programs. And sort of how things went for her, she got established with us. Was really nervous in the beginning because she'd been asked to leave some of the other programs. She missed a lot of appointments early on for several months. She was sort of with us for a week or two and then left, and then briefly got incarcerated, came back to us. And then eventually she was able to stabilize with us, and we did go up to 24 milligrams of buprenorphine, so sort of a high to moderate dose for her, and that tended to work the best for her. She was continuing to use benzodiazepines actually from a psychiatrist, so we did a lot of coordination with the psychiatrist as well to make sure that she was as safe as possible. She started using only only clean syringes and a lot of safe use techniques she had learned at our syringe service program. And she ultimately got a job and is working as a flagger in construction right now. And then she started getting her mental health and physical health needs addressed. She established with our counseling team actually for some additional support beyond her psychiatrist, and ultimately did establish primary care with me at my main clinic, and we were able to treat her hepatitis C successfully and have her see GI to get her Crohn's disease managed. So I think that's sort of just one patient story, but there are a few other stories can be described There was a recent Seattle Times article that you're welcome to read to learn a little bit more about some of our patients. This is down on the left is part of our team kind of doing our daily huddle. And we huddle at the beginning and the end of each day to discuss patients. And then on the right are two of our amazing patients. And you can read their detailed stories sort of and how this model worked for them. And then also want to just share a couple patient voices. To me, what patients are saying is the effect is really what I care the most about. And one person, said early on, only 1 week into his medication, just a testament to the power of buprenorphine. He said, I don't remember when I last felt this normal in my entire life. And another patient at the end of our very first clinic visit and he is a patient who had not been to any medical care for a very long time. And again, had a significant trauma history that kept him from medical care. And at the end of our visit, he said, oh my gosh, I just told you a whole bunch of things I've never said out loud. I've never been somewhere I can say things so honestly. And then folks, also someone who said, I realized I actually like myself. I have the clearest thinking I've ever had. Heroin numbed all of my emotions, even the good ones, and I feel them again. And then the last one I'll share is just, I want to thank you guys for all you do. I don't know where I'd be without you. I felt myself slipping backwards and felt like no one cared about me. I'm really glad I have you guys to help me with everything. That's someone who's been with us intermittently over the course of a year, but sort of was always welcome back no matter how many times he left the program and then returned to us. So this is all great. I'm describing what I think is really dreamy. But also realize that, not everybody has access to a clinic like this. Not everyone is going to go out and start a clinic like this. So, let's think about some things that you can do sort of on a small scale and a larger scale, maybe to implement some of these principles into the places that you all work or the places in your community. Any ideas that folks can think of, like things that they might be able to do in their own practice, in their own community, whether that's on the smaller or the large scale, besides just starting the same type of clinic?
There are two comments in the chat, just as you were finishing those last slides. One is learn your resources in your area to better access treatment.
Great.
Your clinic is a model for what every rural community needs to invest in. And it's very difficult to link clients to primary care in the homeless sector that I work in Michigan.
Yep, absolutely.
And need to continue to advocate for the patients.
Yep, great, absolutely. Anything else? We've been able to get MAT into the jail prior to release, which is excellent, and I'm sure was a heroic effort. So congrats. Seattle was just working on that as well. Yep, and I think that, just that's a side comment, but huge, we know that the risk of dying by overdose in the 2 weeks after release from incarceration is tremendously high. So people getting started when they leave is huge. And then importantly, being linked to somewhere where they can continue. Someone else said education to providers and staff for not discharging patients due to missing appointments and using drugs. Yeah, absolutely. The gentle but persistent education, 100%, yes. Great. These are wonderful. And these are just some of the things that I think of. So sort of on the individual level, things you could, do a little more easily and simply. You can incorporate counseling about safer use strategies, during regular medical visits, if you're a medical provider, or if you're doing an MOUD visit, just simple things like not using alone, carrying Narcan, not licking needles, helping folks ensure they know where to access clean use supplies. And then having those resources available to give to folks. You can also, if you're a prescriber, being willing to escalate your dose of buprenorphine when it's indicated, even up to 32 milligrams, which we're really seeing in the setting of fentanyl. Folks are often needing to do that. And sometimes the medication start actually needs to escalate more quickly than we tend to do as well. Just changing the language you use around substance use. And again, as Corey mentioned, teaching other staff. You can normalize ongoing or intermittent substance use with patients. So again, when you're meeting them, a lot of patients are really nervous about, disclosing that they're ashamed to disclose that they have ongoing use. So just normalizing that early on, that is a part of the process. If you talk to me about it, then we can troubleshoot it. And and try to avoid it in the future. So just making sure people know you understand that's a piece of the puzzle. And again, working really hard to always figure out what does success look like for that patient. And then sort of in the more systems level, certainly offering telehealth intakes and follow-ups if you are currently only requiring in-person ones. And again, not everyone has phone access, but it does open up more, and particularly to more rural areas. Loosening the criteria for discharge. So again, not requiring abstinence, understanding that missed appointments happen, late appointments happen. Decreasing requirements for non-evidence-based components of care. And I guess by that, I mean things like, the requirement for psychosocial treatment, definitely wanting to offer it. And oftentimes we all know that it can help many folks, but not requiring it as people are getting started. If you have an on-site pharmacy, trying to get them to offer buprenorphine so you can, work on decreasing stigma more locally with your own pharmacy. Hiring a nurse care manager who can accommodate more walk-ins and flexible appointment times, hiring a peer in your setting, and they can really help enact the harm reduction approach. And then, sorry, I'm just reading a couple comments here. So yeah, investing in co-located services and improving relationships between complementary agencies and services. Absolutely right. I think as we have learned through this, it is so easy to, it's easy to work in your healthcare silo or your social service silo. It's very challenging from a system standpoint to work across organizations, but it's so powerful for the people utilizing those services. So I think it's well worth our hard efforts to try to collaborate and make co-located services and be in the community as well. And then someone else said, also working with prison diversion programs to educate them on MAT to ensure that participants can continue, yes, during their participation with the court, 110%, yes, wonderful. And what about the limitations placed on programs that are licensed through the state? Oh yeah, and tell me, I'm curious a little bit more about what is behind that question, or what sorts of limitations, maybe if someone can type in, or if someone wants to respond to that, who knows the Michigan landscape more than I do. Yeah, so in the meantime, while that person's maybe typing in a little bit more. But yeah, so anyway, I think, if we are able to adapt, you must have a urine drug screen every 2 weeks. For the first month of treatment. Okay, license to the state. Oh, interesting. So I guess I would say two things to that. One would be, if you want to get vocal on the larger level, as changing the system and changing what those rules are at the higher level, which of course is a much heavier lift. And then I think, what you can do if those aren't going to change, right? It's just, you can do a lot of gentle counseling with your patient, understanding, hey, this is the reality, is you're going to have to go through these, but how to help the person feel less traumatized by doing them, how to help counsel them on how to handle the results. So I think you can do a lot on the counseling end, but ideally changing some of those rules in the longer term. And then someone else asks, do you or anyone see MAT patients and kratom usage at the clinic? Yes, we do, more and more. And I think we're trying to learn to ask about it more. There was just an excellent talk, a couple of weeks ago about kratom. And yes, for sure. And I think it's something that we need to be asking more about, because a lot of times folks aren't disclosing it. And it can certainly, interfere a little bit with starting buprenorphine. So that's something that we're trying to ask about more commonly than we have been so far. And then we at Helen Newberry Joy Hospital have a patient admitted with injection view. Oh, okay. Not sure how or why. Yeah, and folks, probably many folks know this, but some folks will attempt to inject buprenorphine to sort of get a better high from it. And the way Suboxone is formulated, it's buprenorphine plus naloxone together. And the whole idea is sort of a deterrent to injection, because if someone takes it appropriately, the naloxone portion should be inactivated. Sometimes folks are on a buprenorphine only formulation though, and will inject it, attempting to get a high from it. So maybe that's what happened. And then let's see, I'm just looking at where else I am on here. Yeah, how long is your program in terms of months, years, or approved for ongoing buprenorphine treatment? Yes, we are, we definitely counsel folks that, we anticipate this is a long-term medication, think about it like their blood pressure medicine or their asthma inhaler. Some folks do go off of it, but we tend to know that folks do better if they stay on it, and we know that it's safe in the long term. So we encourage sort of chronic use, but if folks are interested in going off, we do a lot of counseling about sort of like when is the right time, and then how to do that, which is usually going down extremely slowly, and sort of making sure that everything else in their life feels very stable before thinking about going down at all. Oh, great. And somebody says there's going to be a roundtable tomorrow regarding kratom. Excellent. Do we offer Sublocade? I wish, and we are working toward it. We do not yet. It's a little bit more complicated, as you might know, or so whoever is asking this question. It's a little more complicated, and our clinic hasn't yet sort of figured out sort of the safety issues with it, and in terms of how it gets delivered. And there are a lot of logistics involved, but absolutely we are trying to. Our sister clinic, the one whose data I shared, the Seattle-King County Public Health, they do offer it. And so we work closely with them if anybody would like it, or we think someone would do better on Sublocade. Great, and you can register for the Kratom Roundtable there. Great, well, I know we're almost to the end of time, but I'm totally thrilled to answer questions or talk for 2 more minutes if we have the 2 more minutes. But I'll let, well. Does buprenorphine address anxiety issues? Very interesting. I don't know that anyone's actually looked at that in the data. Anecdotally, I would say yes, but not probably because it's like necessarily targeting those pathways in the brain, but perhaps more because anxiety is often tied up in using substances or needing to go get your next substance. And so if someone's on buprenorphine, I've definitely had patients say that their anxiety can improve. And I would say also, interestingly, and I think important in counseling patients who are starting buprenorphine, sometimes folks will actually have a significant worsening of their depression or anxiety when they do start. Reason being, if they suddenly decrease their other substance use, that's what they were using to manage their anxiety, their depression, their trauma, and suddenly that substance goes away, there can be a transition time where things actually feel harder. And that's where I think, psychosocial counseling and additional supports are vital during that time. And someone else says, how do you listen to requirements for MAT programs when certain medications cannot be prescribed if someone's actively using certain drugs? I'm trying to think of what, if someone can share maybe a little more like an example of what they're thinking of, that would help me answer that one. Yep, often clinics will kick people out of treatment if using benzodiazepine. Yeah, and this is something that I think 5 years ago now, the FDA actually came out and said explicitly, that benzodiazepine use is not a reason to discontinue buprenorphine. But folks still have a lot of anxiety, I think prescribers do, about that. And, I think, as much as possible, I would, just offer the counseling and the thought that sort of from a harm reduction standpoint, and we know that a benzodiazepine and buprenorphine can interact. And someone who's opiate naive and benzodiazepine naive, taking them together would be very, very dangerous, even at a low dose. But someone using heroin or fentanyl plus a benzodiazepine is, infinitely more dangerous than buprenorphine plus a benzodiazepine. And so, we definitely continue folks, but we do a lot of very specific counseling with them. And if they have a prescriber of that benzodiazepine, we try to connect with that prescriber as well. And then can Subutex, and sorry, whenever I have to stop, Tim or somebody, you can cut me off whenever we need to. Can Subutex help with alcohol cravings? I recently had a client say that it was helping her. I actually I've heard people say that Suboxone, so basically the same thing, that buprenorphine does help them with their cravings. Again, I don't know that any big studies have been done. Maybe someone has read one, but anecdotally, I have seen it happen for folks. So I certainly, it's not FDA approved to prescribe it specifically for that. But I think if it's an additional benefit, then that's wonderful, right? And we have a lot of co-occurring use of opioids and alcohol. So I think alcohol is something that we often don't address well. So I think it's a wonderful side benefit if it happens. Great, and I think folks have to go. So thank you everybody for your time. And my email is here, and I'm, I love this work, and I'm totally happy to have any of your feedback, thoughts, comments, challenges. So please do reach out if you need to. Thanks.
Thank you all for joining. Your local behavioral health consultant from the Michigan Opioid Collaborative will be reaching out to you here on the coming days to provide a copy of the slides, as well as the PDF with the credit information and a touch base. Thank you all again, and thank you, Dr. Hutchinson.
Thank you. Take care, everybody.